Well, good afternoon, everyone, and welcome to the latest installment of the Health Innovation Series put on by St. Paul's. I'm coming to you from here in downtown Vancouver. It's a real privilege to be on the unceded territory of the Coast Salish Nation, including the Musqueam, Squamish, and Tsleil-Waututh nations. We're grateful for their stewardship of this land. For those of you who I don't know, I'm Paul Hollins. I've been a community leader, volunteer with St. Paul's for almost 20 years. I'm currently the chair of the St. Paul's Campaign Executive Committee. My son was born at St. Paul's. I've been involved for a long time with the foundation, and it is a real pleasure to be your MC here this afternoon in the second of these innovation series. Let me start with a few housekeeping notes. First, I'd like to point out that even though we are here in a studio together, we're all following Dr. Bonnie's social distancing rules. Next, the webinar is being recorded, but only the presenters and panelists are visible on the screen. You're not in camera, and everyone else is muted. In terms of our agenda, we'll hear from two presenters today, followed by a Q&A. You can submit your questions by typing them in the chat box on your screen. Now, feel free to submit them as you think of them. You don't have to wait until the Q&A is started. You can also vote for the questions that other people ask by clicking on them, and we'll get to those first. Okay, so let's get started. Today's theme is about how the new St. Paul's will make the impossible possible, and how we're harnessing innovation to improve sustainability and resilience in healthcare, and in fact, beyond healthcare. So, for a little backgrounder, the new St. Paul's at the Jim Pattison Medical Center is poised to become part of a globally recognized R&D ecosystem, very much like Silicon Valley, but for health sciences. This vision was further cemented just this past May when BC's first Innovation Commissioner, Alan Winter, recommended that the new St. Paul's become the cornerstone of an innovation precinct in the False Creek Flats neighborhood. So what does all that mean? It means that Providence Healthcare and the new St. Paul's will be a magnet to attract and grow BC companies in life sciences, biotech, AR, VR, and digital health. Now, the impact of all this resonates far beyond the new campus. It's intended, and it will be, a catalyst to spur BC's economic growth and prosperity, particularly as we come out of the impact of this global pandemic. So in short, we're on the cusp of an incredible opportunity, really a once-in-a-generation healthcare project that brings together business, investment, and research opportunities from across BC and beyond. The tie that brings all of this together is really strong leadership and a very clear, big picture vision. As Fiona says, we're not interested in doing anything other than that which will make a difference in the world. So our first speaker, and I'm absolutely delighted to introduce her, is Fiona Dalton, a wonderful leader, and most importantly, the president and CEO of Providence Healthcare. Over to you, Fiona.
Thank you very much, Paul, for your kind words. I think it's very true what they say about the worst of times bringing out the best of people, and the last 4 or 5 months have been pretty extreme for that. I've found a lot of hidden strengths, and my personal hidden weaknesses have on occasions become less hidden. But I do know that we have found out since the 8th of March, which was the day when the first Canadian citizen died of COVID here in Vancouver, is that what we thought was impossible is in fact possible. That week and the weeks following, we did leap into the unknown, and we transformed our hospitals. We created COVID wards, we emptied space out. If you go past St. Paul's and you see the kind of spaceship-like silver tubes coming out of the red brick building, that's the creation of the negative pressure rooms in the emergency department, which were done over a weekend. And up in the attic of St. Paul's, we now have a high volume virology lab, which again was created over a weekend. because we needed to do it. So we did a load of things that we never thought we would have to do or we could do. But we were also very conscious all along that we also had responsibilities to all of our other patients, and we had to empty the hospital out. So we turned around our models of care to create virtual care models that are now being used right across Providence, from the renal clinic, the cystic fibrosis clinic. Our prenatal classes for expectant mothers are now done virtually. And these initiatives are priming us for the new models of care that will be incorporated into the new St. Paul's. I'm determined that our new normal will, in at least some ways, be better than our old normal. And we have shown what can be done and how quickly things can be done. But the pandemic has also shown us, I believe, the cracks in every society. Across the world, we've seen how the virus has cruelly highlighted the migrant workers who live in cramped accommodation with no access to free healthcare, the poorly paid factory workers who can't afford not to come to work, the vulnerable seniors who are living in accommodation cramped without their own room. And I think that that has touched all of our hearts, and our social justice value, which runs so strongly through Providence, and it has mobilized us. So that combination of what we can do and yet the immense need to say we need to do more, we need to do better, and we need to be more innovative even than we have been before, as a healthcare organisation, as a community, and as community builders. And the time to do this is now. The more of these large systemic changes that we can make now, the better prepared we will be as we continue to plan, build, and move towards the new campus. And we have this amazingly exciting once-in-a-lifetime opportunity for healthcare providers, patients, and the community at large. And we know that Station Street will be a stunning campus. The buildings will all be brand new, they will all be state-of-the-art. But of course, healthcare is never about buildings. It's about what we can achieve in those buildings, and in that space which is specifically designed to be a catalyst for change. My vision for Providence and St. Paul's is always that it's the organisation where the best people want to come and work and where they are enabled to be their best. And I think that's what this campus is about. And our other key value is around partnership. We don't do things on our own, we do them in partnership. And we will be at the heart of BC's innovation precinct, and the partnerships which we are beginning to create, and we can do even more with the community, with the not-for-profit and the private sector, mean that I think we truly can change the world. So innovation has always been embedded at St. Paul's, right from that first day, over 125 years ago now, where some brave women came from Montreal because they knew that they were needed here to create a small hospital on the muddy end of Burrard Street. And that innovation is driven by compassion and social justice. It empowers our staff to bring their ideas and creativity to work, and that culture of entrepreneurship, and our vision that everyone's voice gets heard and that everyone has an opportunity to be part of improving things and innovation and changing the world for the better. So one story from last year, a young woman was brought to St. Paul's in labour, and she was homeless, sleeping on the sidewalk, and had a 10-year addiction to opioids and other drugs, and had gone into labour on East Hastings Street. Was brought to St. Paul's, had her baby, and whilst the baby was in the neonatal ICU, she was able to stay at our transitional care centre. And what that meant was that, first of all, she was actually able to see her baby every day, but she also received care through the addictions clinic. And it's credit to her. She worked really hard. She was supported by the maternity team, by the Indigenous Health and Wellness team as well, in the transition back to the community. So that was a year ago. Alyssa and her son Hazen have now talked to us and happy to have their story in public. She has completed a long-term care treatment program, and her and her son are together in a new home. And she's working towards a brighter future for her family. And I really love this story because it does demonstrate what we will do to wrap our arms around our patients and our communities. And it also demonstrates what it is about thinking outside the box, that it's not about a kind of a narrow medical model of get through birth and achievement is baby. No, absolutely, our role is to look after the whole person and the whole family. It is thinking outside the box in the same way as the cardiac team said, how could we replace a cardiac valve without actually opening the chest? And that's where the TAVI program came from. In the same way as the HIV team said, why don't we go and find the people who are HIV positive and not just wait for them to come sick with AIDS to St. Paul's? And I think that's the culture that runs through every service at St. Paul's, that thinking outside the box. How can we do it differently, and how can we look after the whole patient and their family? And so this innovation at St. Paul's becomes an engine in terms of its direct impact on health and family and our social structure of society, but also its ability to create sustainability and resilience in health, in society, and in our economic recovery in this post-pandemic world. And I think that Station Street in particular is then an opportunity for municipal, provincial, and federal government to invest in that innovation and leverage the exceptional and amazing support that we already have from our community, and especially from our donors. And we can see how Alan Winter identified that Station Street and St. Paul's could truly be a catalyst for the robust economic recovery that, combined with our equitable society and our resilient healthcare system, could create BC as truly world leading. So right now, researchers are doing amazing work in a 100-year-old building that truly is falling apart around us now. And St. Paul's is always known for punching above our weight. Someone said to me that we are the mouse that roared. But imagine what we could do with a new hospital and a new research centre. And I always say imagine, but actually soon we won't have to imagine, because it will be here. And I absolutely know that in 6 years we will be leading the province, the nation, and we will be changing the world with our innovation and research capabilities. And we'll have brought together partnerships between industry, academia, and the non-profit sector to develop, demonstrate, and advance life-changing health solutions, products, and technologies. So I just wanted to end by saying thank you so much for being part of this journey. We're incredibly grateful for all of your advice, support, and cheerleading as we go on this incredibly exciting journey. Thank you.
Well, thank you, Fiona. I know I speak on behalf of everyone involved in the St. Paul's family, but all British Columbians when I say how grateful we are for your leadership and for the guidance of all the other healthcare leaders at this really important time in our history. You know, folks like Dr. Bonnie Henry or Minister of Health Adrian Dix, and all the people who are on the front line. As we look forward, we have confidence in that skilled, unflappable, forward-looking leadership at a time of great crisis. Apparently we already have some great questions in the queue. This is a reminder, if something Fiona said or something Jeff will say in a few moments sparks a question for you, be sure to put it in. Which then does bring me to introducing our second speaker today, presenter. It's Dr. Jeff Pike. Jeff is an orthopedic surgeon and the physician director of clinical planning for the new St. Paul's redevelopment project. He's not only been on the front lines of the pandemic, he's been leveraging those experiences to ensure that the new St. Paul's will deliver and transform the care that we're going to need going forward. He works 3 jobs and is doing a superb job at every single one of them, and this in particular. So I'd like to turn it over to Jeff now.
Thank you, Paul. The first thing I'd like to say is that it's a great privilege to be speaking to you. It's always exciting to have this opportunity around such an extraordinary project, which I've been involved with for the last 4 years, and very excited about what this could mean for all of us. It always harkens back whenever Fiona, shares stories to the initial days in 1894 of the sisters riding into town. What's fascinating to me now is how we've come essentially full circle. And at that time, the focus was on the most vulnerable. And here we are back again, 120 years later, focusing on very much the same thing. There's been tremendous advances in many corners of medicine, but at the end of the day, that compassionate person and patient-centered care, which was where we all started, is actually front and center so much of the time. What's changed in many ways is the complexity of the patients we are now seeing every day. Costs are rising, the challenges from social determinants of health are more and more recognized. This is a slide from, or a picture from a couple of years ago, but it's worth repeating here, I think, that in the COVID-19 last few months, that the mortality rate in the downtown east side around First Nations directly related to the opioid crisis has doubled compared to this time last year. We are still struggling, and we have a lot of work to do. And that's where this vehicle as a means of generating new solutions to problems that have been increasing over the last few decades really is such a wonderful opportunity for transformation. I want to introduce briefly Tamara. Tamara's been involved in the project, and as a patient of mine, that brings it very much down to earth for me. She has multiple providers. I'm her shoulder surgeon. She has 4 or 5 other orthopedic surgeons, has a hematologist, a rheumatologist. As a way of prefacing what we're trying to change for an individual, she is a great example. She has struggled with appointments and investigations and upcoming surgeries since she was a young girl. And nothing has changed for her except that she is a savvy person who owns her own business and is able to navigate the murky waters of access and care very, very well. But many people are not as savvy and as sophisticated as Tamara. And for those who don't have the skill set to navigate this difficult environment, that's really where I think we need to focus our attention. These key populations or priority populations that the ministry identified starting really in 2014 with some key white papers focused on those populations that are struggling with access. Mental health and substance use, the frail elderly, multimorbidity, and those with multiple chronic diseases, of which Tamara would fall into that category. For many of us on this call, the access to the health system is really episodic. It's now and again. We have a sore knee, we have some chest pain, we see a cardiologist, an orthopedic surgeon, get care, and we're well again, return home. But for our patients who are struggling with multiple areas of challenge, it's a different story, and that's really where we have a great opportunity. This goes back to 2014 when the ministry was articulating kind of what are the priorities in this central turquoise box where we'd like to focus. We're fortunate to have been thinking about where we were going in this project at that time and say, well, how do we address as many of these priorities as possible? Patient-centeredness, access to quality diagnostics, how do we improve our acute care system? Each of these things was a question that was put before us that we responded to at that time. What do we do from there? How do we consider this opportunity? Well, I've always been struck by this the Sufi parable of many eons ago, which relates to Herb Simon, a Nobel laureate, in this concept of bounded rationality. What is this that's in front of us? If a blind person is feeling that, and this is an elephant in the room, and all we have to go by is the corner of this ear and the side of the body, and that's all we know, then that's what we think that an elephant actually is. But if we can put that together with the other parts of that system, the trunk, the tusk, the tail, then there's a different picture of what an elephant is. We take that even broader. What's the context of this elephant in an environment? This is very much where we are in healthcare. We have some absolutely brilliant clinicians in specific specialties that are very good at managing one aspect of a person's body, life, and their family. But when it comes to integrating the whole, gone are the days where there was a single physician, a single surgeon who sat in the single room together every morning and every evening admitting patients. That was the sum total of knowledge at that time in the single room. That is very difficult to achieve today, and essentially our opportunity in this new construction is to think about how we do that. When we started, it drilled down to several different guiding principles which have been sort of our guiding light as we've kind of worked through this very complex project. Focusing on exceptional care, what it means to have not only a great outcome, but Fiona's story of the woman who gave birth and was able to stay with her baby. What does it mean to have an excellent patient experience? It's not just about the health outcome, it's also about how that goes for patients and their families. Each of us on this call can recall right now what has gone well and what has been more challenging. And I'm willing to bet that most people have access to wonderful people that can guide them through the process and the system really well. A key one that I want to flag on this slide in particular is flexibility, because we certainly do not know what our exact demands are going to be in 5, 10, 20, or 50 years. So we have worked really hard to throw scenarios at our design to ensure that we are as flexible as we possibly can as we move forward in each phase. That means looking at partnerships. It means trying to understand what does it mean to continually learn as an organization. How do we integrate our learning systems with research as well as the teaching avenues of our organization? How does new technology change how we can provide care? One good test early, and all of you will be familiar with it and probably thinking about it, what does the new St. Paul's mean if COVID-19 happened today? Well, the first thing to say is that we'd be in better shape than we are today. There's increased capacity. We have more beds, all of which are single occupancy. That is, in the current situation, we're shooting at about 15 to 20% of single occupancy. Limiting exposure from a simple one-way flow system. It's simply not possible in our current state. We have about a third of our outpatient capacity is accessible from the street level, which again is almost zero in the current state. Our ability to intentionally place protective equipment next to care areas can be done much more intentionally than it was when the current hospital was originally designed. Containing outbreaks, if they were to occur internally to the hospital on a particular unit or ward, is certainly much better. That has to do with airflow, air handling, the ability to create outbreak control zones in parts of the inpatient unit. Hand washing, you probably won't be able to take 2 steps without running into a hand washing sink. Technology as well, Fiona already mentioned our virtual capability, but we're looking for a universal connectivity so that every single care space, whether it's an outpatient exam room or the operating theater, has the capacity to connect virtually. That means not just connecting with patients at home, but also connecting with providers that are perhaps in some of the most remote parts of our province who are struggling with resuscitation in their tiny little emergency space right in front of them. And of course, going back to that flexibility, the ability to create knockout panels, which essentially from a construction standpoint, assume that we're going to be making changes and that we need to have panels that can allow that. So bottom line is we're in much better shape in the future when it comes to pandemic resilience. Just kicking it back up again, we have come a long way at Providence from the old division department structure that has surgeons over here and medical professionals in another part of the hospital. As we think about how do we wrap care around particular populations, it means that we need to work differently than we have. Our neighbors will be different. And so this should be and will be dynamic. Every time this type of slide goes up for those looking after patients at St. Paul's, there's always a suggestion of, well, we really should be better suited over here or in this area. And it should be dynamic. We should be changing all the time. When we started with COVID, for example, it was the feeling it was just a respiratory illness, and it would really sit in this diagram with the lung, sinus, and allergy group. But as it turns out, there's problems with blood clotting, there's problems with neurology and perhaps cognitive decline following some of these illnesses. So our ability to quickly pivot and change who the neighbors are caring for a particular identified population is new, will be new to an extent for us. It is inspired by the likes of Cleveland Clinic. It's inspired by the likes of Kaiser Permanente. But our opportunity to do this in a really meaningful way is fundamental to our future. When we thought about these key populations listed down the left-hand side there, in our current space in the core hospital, we have a space that specifically addresses mental health, addictions, the urban health kind of population. Healthy aging as a distinct population. We've had singular conversations with multiple specialists and providers around that population. How we manage complexity and multiple chronic diseases in an outpatient care center. Integrating across our procedural floor. Nobody knew that John Webb was going to create a percutaneous heart valve 15 years ago. Now our ability to scale that is limited because that was being performed in one small part of the hospital. By integrating all of our procedures into 2 floors gives us the greatest flexibility for that. So where are we now? This just shows you where the current hospital is and where we're moving to. The new site has been rezoned. The core hospital example or indicative design, as it's known, has been completed, and the business plan was approved almost 18 months ago. So right now, we're in the midst of defining the evaluation for the core hospital. But what I want to spend the last few minutes on is this clinical support and research center, because to me, it's essentially an innovation hub. It's yet to be fully worked out. It's where we need your help and advice the most at this time, and it's one of the most exciting parts of this site. Well, the first thing to point out is that above that dotted line is our new St. Paul's project, the core hospital. That goes from the acute services, which you know, the emergency department, the intensive care unit. That's where patients with acute problems and unstable chronic diseases would be cared for. The same is true for our outpatient care center. The clinical support building, which is as much a part of, or will be as much a part of our patients' experience as the core hospital, is different. It fills a different gap, and really it focuses on outpatient services that are more for non-complex patients and general care, and specifically links it with our research centers, Heart-Lung Institute, HIV, Center for Excellence, CHAOS. These groups will be flowing back and forth in a way that really focuses on that center point, that nexus of travel. So the intersection of our clinical care, our physician homes and groups, our research components are specifically and intentionally colliding as we are spending time in this campus as citizens. But I ask you, is that enough? And I would say that no, that's probably not enough. What about our innovation space? What does innovation space mean? Well, I'll work through that in a minute or two, but at a high level, we have academic partners who have been our perennial champions and partners for decades. But what is missing here is our industry partners who have typically not had a home or felt strongly partnered to our Canadian public healthcare system. That has to do with our digital health partners, data scientists, biotech companies, pharma. It doesn't have to be us and them. This is an opportunity for us to say, what is our ecosystem that is going to bring the best care for our patients? Where are we in the project? Well, the main thing to point out here is that both of these buildings will open at the same time in mid-2026. Although the Clinical Support and Research Center has not yet had a business plan submitted, the total construction time is much less, and so that allows us to essentially learn from what some of the gaps are in the core hospital, address them as we're moving towards the business plan submission for the clinical support building, and move from there. Now, typically, the design process gets more and more narrow each phase, from building to department to each room, and we lock down each phase as we go. This essentially assumes we know exactly where we're going to be at the end, and we don't look back very easily. Now, that works well if we have a fairly simple or even a complicated problem where we benefit from converging to the solution, to sorting out discordant opinions, reconciling them, and then moving forward. But once we get into this outside of our area of certainty, outside of broad agreement, we get into this complex problem space, which is squarely where the clinical support and research center is based. So we need to get creative. We need to get really creative and actually get out of our fairly narrow thinking to say, how do we innovate? What does innovation actually mean? This is one definition, essentially, that we're driving towards new or better ways of doing things that are valued. It's not enough just to create something. It needs to be adopted for it to actually be an innovation to a meaningful extent. So that's just not one or two people or those in our group. That means taking that discovery in a lab in St. Paul's and impacting 100,000 lives next year, not 10 years from now. This is another definition from Clayton Christensen, the late founder of disruptive innovation in many ways. What I like about this is that it speaks to sort of the components. It's about people, it's about money, it's about the materials and information that we have to transform to create something new. So here we are between this highly creative space where we're not necessarily implementing on this x-axis and deviating from the status quo in our very creative space. Just incremental improvement is not enough. We need to be moving toward this space that's between creativity and improvement towards real and true innovation. Well, how do we do that? I think we need to take stock of where we are. We have 6,700 staff, over 1,000 research staff. We've been very successful in competitions for research funding. But if we look at the components of that concept, we have clinicians, we have our scientists, we have patient and families, but we are not strong and thick with our innovations and innovators as part of our people group. We have some bright stars that have done it because of their sheer individual brilliance. And we have folks who want to partner with us, many of whom are on this call. Our opportunity here is to bring all of the folks in this discussion in the ecosystem into this space. So for us as an organization, there's different terms that I've heard used for this exchanging and the configuration of services and people that allows for exchange of ideas to better healthcare. Value chain integration, the concept of a platform like Uber does with drivers and people trying to get places, and facilitated networks. The concept is the same. It's bringing groups together to exchange information with each other in an effort to improve the value for our patients. So with all that said, the vision has arisen that essentially we want this space to be a collaborative platform for discovery and learning, attracting the best people to deliver excellence in care, research, and innovation that's sort of driving this engine of improved systems of care. These are some of the guiding principles, which probably aren't surprising based on what I've just said, focusing on excellence, flexibility, designing quality spaces that really enable collaboration, and integrate discovery into every step of the care experience. So here we are. This is the campus. As it's shaping up now, it'll look different from this, but these are the main components. The research support, the Clinical Support and Research Center is something that I'd like you to spend some time thinking about and what it's going to mean for solving some of the problems around virtual care, integrating value for patients just like Tamara. This is my last slide, but what I want to focus on here on this one is that something like this, which is truly so different from anything that's been done in BC to this point. There are great examples in Toronto, like Mars, like the Garfield Center in Oakland with Kaiser Permanente, like Mayo Clinic and their Innovation Center. But in order to make something like this happen, it really is truly reliant on the community, and the foundation, in my experience in this project, has been that linchpin of community to making this happen. So I ask you for your support. I ask you to ask us hard questions about what we need to be thinking about as we make this a reality moving into the future. Thank you.
Well, thank you so much, Jeff. You can start to see the framework of how innovation is going to change at St. Paul's and some of the opportunities that exist in terms of collaboration. It's fantastic work. I'm hoping all of this has sparked some questions and some interesting lines of inquiry. We've got a great number of people on the call with us today. I'm now going to turn it over to Dick Villette. Dick's the president and the chief executive officer of the St. Paul's Foundation, and is truly one of the great leaders in this area in Canada. I'm so fortunate to have the chance to work with him. So over to you.
Thanks, Paul. Thanks, Jeff. Thanks, Fiona. I know Fiona's still on the line with us. You can feel the passion come about this project, and I can feel it just listening to you. I know there's some great questions that have come in, so I'll facilitate that for the coming minutes here, the remaining time, and hopefully we can get some of the tough ones out on the table, because I know you've covered a lot of ground, both of you, so it's great. Maybe what I'll do is I'll start off by just throwing one out to the group, because it's one that kind of resonates with me all the time. Is what do you, if someone said to you and you got in an elevator and you had like 30 seconds to the bottom of the trip, what's the most exciting part for you about this project? And for me, I'll go first. For me, just listening to you and Fiona talk and Paul, your intro, for me, it was the fact that this is going to be purpose-built. The ability for us to actually look at the best of the best in the world and actually implement it into what we're going to build on the new St. Paul's of the Jim Pattison Medical Center, to me is the most exciting part. But I'd love to hear from you and Paul and Fiona. Maybe let's start with Fiona. What's the most exciting part for you, Fiona? Is Fiona still with us? Here she is.
Thanks. I agree with what you said about the purpose-built nature of the hospital, and would also echo what I said earlier in terms of a place where the best people want to work. The other really exciting thing for me, which I think is unique, is around that this is a city centre urban rebuild. It's not a greenfield site, and so we are bringing the brightest and best minds to work in the heart of a community where social justice determines that people really need our care. And so we're focusing our innovation on the most deprived part of society. And I think that really is unique in the world.
Yeah, very well put. Thanks, Fiona. Thank you for that. Paul, when someone asks you the question, what do you say?
So I think the thing that's so unique about this opportunity, it's obviously a big campus, but it's the willingness of the organization to take things apart and fundamentally reconceptualize them and put them back together differently. We know the system that worked 10, 20, 30 years ago won't work very well today, or 10 years from now, or 20 years. But systems have inertia, and they're hard to get them to change. And the organization is so committed to taking things apart and reinventing how outcomes are achieved. That's, for me, fundamentally, I think, what's so exciting.
Thanks, Paul. Thanks. Well, we've got some great questions coming in, and this is one that I think that I think has been top of everyone's mind. It comes to us from Fred. What's being done to engage the community surrounding the new St. Paul's, such as individuals, families who live there, as well as small and large businesses? As you can imagine, this campus is going to be employing about 10,000 people at any given time. So maybe, Jeff, I know you've been involved in the community engagement sessions, so what's being done?
Well, yes, it's a great question. I think, the first thing to say is that Tamara, who I showed you there, this was the first time that during the procurement, so we're in the competition phase and currently in evaluation for whatever consortium is going to build the new St. Paul's Core Hospital. This is the first time in BC's history that we've had patients actually involved in the user groups with physicians and the rest of the clinicians in those groups. ever happened. So it's been really important, I think, to have the clinical input front and center. That's my main passion, is to ensure that the 100 patients that I see in every 2-week period, their opinions are brought to bear on the project. Currently it's a slightly strange time where we're under this kind of radio silence where we can't share any of the details of the competition phase other than those patients who are actually participating. Prior to this, we had a patient and family user group individually. There was community engagement over the course of about 10 different sessions, engaging various parts of the city in terms of what the impact would be and gathering their input for what the new St. Paul's should be addressing. And frankly, it was very, very important in determining, making sure this is a patient-centered project, that every decision we make is to improve the care for patients and families. And so I think to this point it's been effective. I think we're going to be ramping up again once this competition closes, and we can be more open about who we're going to be working with to complete the design.
That's great. Thanks, Jeff. I know there's a couple of questions around Fiona, the group on the call really enjoyed your story about the pregnant woman who was addicted to opioids that gave birth at St. Paul's. We know that the RAC, the Rapid Access Addictions Clinic, and the Hub are going to be moving to the new St. Paul's. I think one of the biggest questions that I get on a regular basis is, how do we integrate mental health and substance use care that currently exists at St. Paul's, but how do we make it even better at the new St. Paul's? Because we're doing what we're doing now in a 125-year-old building, but how do we actually move that into a world-class facility and make it work better?
Well, you take that. I think one fundamental thing is that the complexity of our patients is not new, but our medical model and how we receive them is somewhat outdated, and that we typically would receive somebody in duress at the front door who it's not clear whether they're in duress because of psychosis related to addictions or substance use or a psychiatric condition. So essentially, we've tried to focus on meeting the complexity of patients at the front door and having the facilities to care for them in terms of their medical safety through the emergency doctor and that team, security, as well as a shared model that doesn't assume that it's addictions or psychiatry that needs to be the primary caregiver. And essentially that speaks to that team-based model of wrapping care around the patient until such time it becomes clear what the patient's needs are in that first phase. That's the way we approach the design from the beginning. How are we trying to function? Then how do we design space to look after these complex patient populations? Again, with patients and families helping us to understand where the gaps were that we needed to address.
Yeah, thanks, Jeff. Fiona, anything do you want to add on to that? I know this is near and dear to your heart.
It is, yes. And I am very conscious, as I think one of the questioners absolutely said, that this is actually numerically, this is our healthcare crisis in BC. It's not COVID, it's opioid overdoses. In the middle of the COVID crisis, there was a change to the law around safe supply of drugs. And we are enacting that, but we can do much better and work much more quickly on that. And that's a really fundamental change. The other two things which we're working on, which I think that, well, I know we can continue to advance and accelerate, is in terms of in the community, we have community services in the downtown east side, for instance, Crosstown, VCH also have services. And it's how we work in partnership with our RAC and our Crosstown clinic to ensure that we don't have patients and clients who are falling between the cracks between us. The other angle, just to kind of keep on my theme of kind of thinking outside the box, is that we now have an agreed supercluster project, which is led by our anaesthetists around perioperative care and particularly perioperative opioids, to really help us understand through AI and digital media how we can best ensure that people are not in pain around their surgery, but also that we can start to learn and identify quickly where people are at risk of addiction, so that we can also kind of go upstream and really think, how do we start to address this pandemic in a different way?
Yeah. Thanks, Fiona. And I know in the current situation, mental health and addiction services are integrated through the entire hospital, at every corner of the hospital. So it's really become part of the fiber. And I also think your story shone a little bit of light in that one piece about recovery. How do we connect back to community so that people that are leaving St. Paul's actually can connect back into communities? That's another big one.
Absolutely. And so, for instance, also we took all of the patients in the COVID wave 1 epidemic who needed hospital care for their COVID, but also needed psychiatric care. And that's another example about how you come in example of you're not a COVID patient, you're not a psychiatric patient, you're a person, and you have more than one issue. And I think that we're uniquely set up to look after groups like that.
That's great. Thanks, Fiona. I just want to shift gears because one of the other vulnerable populations that we've been talking about is seniors, and there's a good question here from Ian. He wants to know if we can get a little bit more information about the integrated care for seniors at the new St. Paul's. You want to take that one, Jeff?
Sure, yeah. So this is one that's very near and dear to my heart too, because I think when we started off, one of the most exciting parts of the project was trying to define how we improve services for the frail elderly and specifically. So the Center for Healthy Aging is one of the components of the new St. Paul's project. It's in the context of the whole campus, and so that means other innovators and other folks getting involved with that. But what I can tell you now is that what that means is that there's a dedicated space that is there to serve seniors and the family practitioners and primary care clinicians who are looking after those patients in the community. Currently, what happens often is that a patient is in decline, they miss a few appointments with their family doctor, and that gets missed, and they end up falling down in really perhaps 10% of their functional capacity and end up in emergency and are admitted for weeks, sometimes months, sometimes they never go home. The concept around the Center for Healthy Aging is to provide something that is upstream of that when patients perhaps miss an appointment with their family doctor, that it triggers an outreach from the system, that triggers a home visit from a home care nurse who can recognize that Mrs. Jones is not doing well and needs to have a rapid assessment, not next week, not 2 weeks from now or next month, but today. And that means getting a same-day appointment at the Center for Healthy Aging, where there can be a robust assessment, not just one particular specialist or just one component, but perhaps there needs to be an assessment from occupational therapist in the kitchen. Maybe there needs to be a walking assessment. Maybe there needs to be a cognitive assessment. Maybe there's 5 or 6 things. That means it's a different way of providing care where you're seeing somebody for 10 minutes and getting one thing dealt with. It's integrating across all of those things, creating a care plan based on all of the inputs from those opinions, those investigations and diagnostics, and returning that person home with a strong care plan that's going to be supported by the hospital, rather than the old way, which was essentially emergency admission and then figure it out after the admission. So that's the big shift in terms of thinking, and now we're getting into the details of how we might achieve that.
Yeah, thanks, Jeff. I think that's really a key point. You touched on it earlier about how people navigate through the current healthcare system. We all have nightmare stories about how that happens now, and we can do much better. We have to do much better. This is a good question that came in too. It says, given these crazy times, has there been any delays on the timelines for the new St. Paul's? Short answer, no, which is fantastic. I know Fiona alluded to this. We're going to break ground this year, which is really exciting. I know there's some people on the call that have been waiting decades for that. Paul, you're one of those folks, been waiting decades for this. So we're really excited. We will break ground. We will announce the proponent who will design and build the new St. Paul's. So we're all on track. So it's great news. There's another question there, speaking about vulnerable populations. How will the new St. Paul's better serve people who are affected by other pandemic or opioid crisis? Again, I think it comes back to that whole wraparound that you were alluding to for the elderly, but is that process going to actually work for, say, someone who has concurrent illness with an opioid crisis? Is that the same?
Yeah, it's certainly the same philosophy. I think that as part of that care, I mentioned the person presenting in distress to the emergency department, but that is one snippet in time, one window into the care experience of that patient. They were at home the day before, they were in Kelowna 2 weeks before that, and they're going to be at home perhaps in 3 or 4 weeks. They're accessing services and they're experiencing their health in that whole period of time. So what happens after emergency tends to be somewhat siloed from the next phase. Perhaps it's outpatient care, which is the same philosophy, and having the right providers wrapping care around them, considering things like their social determinants, like their food security, their home situation, how are they retraining for a gainful occupation of some sort. All of those things are a part of their health experience that we haven't really focused on. And part of doing better for particularly those complex populations is thinking around that population in that way, so that we are really taking advantage of what is so special about an acute care campus going forward is the fact that we have multiple specialists. We can't create these brilliant clinicians in a team in every street corner. We can only do it in places like the new St. Paul's. That is the value of such a unique place in terms of team-based care, which is different from the way team-based care gets used so often, which is meaning small groups in perhaps it's 1 or 2 or 3 people. That is not the same as what I'm referring to as around multi-specialty team-based care. So if that person has more questions, I'd love to answer them. We can talk about kind of what that journey may look like, because at every step of the way, we're trying to make it seamless as folks are accessing care.
Yeah, that's great. Thanks, Jeff. And just on that note too, if there are some questions we don't get to here live on this stream in the minutes we have left, we will circle back to the individual who asked the question and make sure we provide an answer for them. So we'll make sure of that. I just want to read this comment. It's not a question, but it's a comment, and I think it's worthy of reading it out. It says, as a granddaughter of one of the founding fathers of Medicare, a Catholic and a keen supporter of the ongoing changes in our medical system, I am impressed. And I'm also pleased to hear there's a strong approach for the elderly. So it's a very profound, there's some great history on the call as well, I'm sure. An interesting question here, though, we talk about, will there be any new services offered at the new St. Paul's on the Jim Pattison Medical Center? And I can only go to the, Clinical Services and Research Center. I can think that is going to be a brand new, for an acute care research teaching hospital to be purpose-built. Sky's the limit.
Yeah, just to add on to that, I think that we know there's going to be new services. We just don't know necessarily what they're going to be. A good example right now is, I mentioned that sort of post-COVID-19 clinic. We are currently developing that clinic at St. Paul's in conjunction with a network across the province. So this is not unique only to St. Paul's. But what I am hoping is that that is a scenario that it needs people, it needs resources, it needs space, it may need technology. It's a great test of our design today. If that was coming online today, now, are we ready for that? And the answer is yes, we can accommodate it. And it makes me feel good when we're able to kind of test our design with that. But it goes back to our flexibility. We should be able to throw virtually any health problem, scale up, scale down, and accommodate it at the new St. Paul's. That will be the real testament. And that's why we have tried to avoid really narrowing and putting fences around specific parts of the program to allow it to grow into the next part of the program in a rational way.
Yeah, and that kind of leads into the obvious question. With all this increased flexibility, are we going to reduce wait times at the new St. Paul's? Is that going to be one of our targets? And I mean wait times across the healthcare system?
That's certainly our goal. I think, again, there is zero issues in healthcare that shouldn't be addressed by this project, and wait times is one of them. How do we more efficiently access services? Yes, we have more services, but it's not a matter of just more, it's how efficiently that we use them. And I think there's a tremendous opportunity as we move into this project. One of the exciting things is that as a change management issue, there is 0 people at St. Paul's who will not be working differently in 2026. 0. And that is essentially not the case for any other redevelopment you'll hear for healthcare services. There may be a new facility, a new inpatient tower, maybe new procedural suites, but it is not the same as everybody, even our most strong conservatives who really think the way that things are done is the way they should stay, are acknowledging that things have to change. And that's an opportunity for us to really pivot the whole system.
Thanks, Jeff. As you can tell, Jeff's the keeper of a lot of information, and we could send all the questions your way, but I'm going to throw this one over to you, Fiona, because I know in early days we had massive conversations about the number of beds. Should it be 550? Should it be 510? Should it be 480? I mean, how many more beds do we have? So with only 115 new beds coming on stream, I think is the question coming to us. And the population growing the way it is, why the number of beds, and why did we end up where we are?
So thanks, Dick. Much of this was before my time, and so I won't take credit for, I think, a really successful battle that was fought by Providence and St. Paul's Foundation to achieve that additional number of beds. And I think for any hospital CEO, if you were given the option of more beds, you'd say, great, yes, I'll have more beds. Having said that, I also know that in every hospital in the world, and St. Paul's is no exception, we have patients who, if we were organised in a different way, would not need to be in hospital. And so I think there is a real challenge to us, and very few of those patients want to be in hospital. Very few people want to be here. If we can organise their care in a different way, in a better way, we can get them home more quickly. And taking the long view, a really good example is if you're brought to hospital with in cardiac arrest, if you've had a heart attack. I think it was only 30 years ago you would be in hospital for 6 weeks, and really you would be on bed rest. And to be honest, there wasn't very much that could be done, but you were here for 6 weeks. Now you come in, you get taken straight to the cath lab. You have your procedure, and you are home within 48 hours. And you will have a massively better chance of survival, and also getting back to an absolutely normal standard of living. And so I think that we need to keep challenging ourselves on that, and that the answer, whilst it's always tempting for more beds, actually the answer is often more operating rooms, more procedure rooms, more diagnostics, so that we can get things done more quickly, that we can treat you and we can get you home.
I think I'll add a comment. I think one of the things that's very exciting about this is we'll actually treat a lot more patients. On like significantly more than the beds will be added, because of, one, the way things will change, and two is the nature and type of the rest of the facility and how it works. And so, the old measure of success was how many beds you had and how it worked. Today it isn't that. It's how many patients do you successfully treat, and that will change fundamentally in this case.
Yeah, that's a good point, Paul. So as we committed, we're going to end on time. We're going to end right at 5 o'clock. There's a few questions we didn't get to, but we will make sure we answer them. And I think most of the people on the call have a contact with someone either at the foundation or within Providence. And so I'm just really humbled and appreciative of this great conversation. I think it keeps us on task, it keeps us accountable, and it drives us to world-class, world excellence. So thank you, Jeff, and thank you, Fiona. Back to you, Paul.
Let me just wrap up. Thank you, everyone who participated. My thanks as well to Dick and Jeff and Fiona for participating. Questions are great. The dialogue is always the best part of this. I think if you come away with just a couple of key ideas, one is the new St. Paul's is truly more than just a building. It is a campus where there's a huge amount of innovation back and forth between researchers, clinicians, innovators, and ultimately patients. And that's what's so exciting about it. And I think this opportunity, and we've said it about 14 times, that this is a once-in-a-generation opportunity to really change healthcare and also to change Vancouver. It's quite remarkable. So this is number 2 in our Health Innovation Series. Delightful to have everyone with us, and we'll be sending you an invitation to number 3 shortly. Thanks so much.